So hello, in this video we'll be discussing about the GI pathology, specifically the esophagus part. We will be covering the different kinds of diseases, congenital, acquired, the types of cancers, and the pathology and the clinical manifestations of each diseases that belong to your esophagus. Okay, so let's get started. The GI tract, as you know, starts from the mouth and ends up in the anus, right? So we'll be dealing about the esophagus, which is almost the first part of the tract after your oral cavity. Okay, the esophagus. So let's talk about what are how the diseases are classified when you talk about esophagus. You can talk about the congenital ones, the cancers, and the acquired diseases. Okay, so the first let me talk to you about the acquired diseases. There is hernias, stenosis, diverticulums. Okay, what about congenital? There are atricias, fistulas, absence of some organ, absence of esophagus, and imperforate anus. And about cancer we'll be talking in much detail later on. Okay, and also an important one in congenital is your Hirschsprung disease, about which we'll be discussing soon. Okay, let's begin with hernia. There are three types: diaphragmatic, omphalocele, and gastroschisis. Okay, in diaphragmatic hernia there is incomplete formation of your diaphragm. Imagine this is the thoracic cavity, this is your abdominal cavity. There is incomplete formation of this diaphragm. As a result, the abdominal contents enter the thoracic cavity. That's diaphragmatic hernia. What about omphalocele? Imagine this is a person and you're looking at him from the lateral aspect. Okay, this is the eyes, ears, this is the abdomen, this is hands. So what happens? The abdominal contents escapes the abdominal cavity through the abdominal viscera through the anterior musculature wall of the abdomen. Okay, so in that case, that's an omphalocele. But if it involves all the layer from the peritoneum to the skin and all those layers herniate out, that is called a gastroschisis. So gastroschisis is more complicated and dangerous than your omphalocele. Okay, these are the three types of hernia that you have to remember. Now again, for omphalocele is just the movement of abdominal contents through the anterior abdominal musculature, but gastroschisis involves all the layers of the abdominal wall and the abdominal viscera. Okay, that's about hernia. Now what about stenosis? Stenosis, specifically if you talk about stenosis, there is pyloric stenosis. You know the stomach, right? This is your stomach. Let's say this is your esophagus and this is your stomach and this is your pylorus part of the stomach. Usually stenosis is seen in your pyloric part of your stomach and usually seen in patients with Turner's and trisomy 18, which is your Edwards syndrome. Turner syndrome and your trisomy 18. So usually in patients with pyloric stenosis, they present with projectile vomiting or non-bilious vomiting. Why is it non-bilious? Because the food has not yet reached the duodenum. In the duodenum is the part where the bile is poured on, right? So it has not reached the duodenum, and that's why due to the stenosis here, the obstruction here, there is non-bilious vomiting and projectile vomiting. The patient vomits in a projectile fashion. Okay, these are the important clinical manifestations of your pyloric stenosis. Just something that you must remember. Now what about diverticulum? Diverticulum is outpouching of a tube in simple terms. Imagine this is a tube inside your body and an outpouching of the tube separately is your diverticulum. And the most famous diverticulum we all should know about is your Meckel's diverticulum, which is seen in your small intestine. Okay, this happens due to the absence of involution of your vitelline duct during development. Okay, so Meckel's diverticulum is a diverticulum present in the small intestine. It happens due to the absence of involution or the lack of or improper involution of your vitelline duct. There's a rule of twos for Meckel's diverticulum. It affects 2% of the population. It is usually 2 feet from the start of small intestine. It is usually 2 inch in size and it's 2 times more common in men than women, and usually the symptoms start occurring during age 2. Okay, now let's talk about some congenital disorders, starting with Hirschsprung. Hirschsprung disease is usually seen in patients with Down syndrome. Okay, and when does that happen? Hirschsprung disease is common to your colon, is seen in your colon or your rectum. Okay, so what happens is in Hirschsprung disease, during the development, the neural crest cells that are supposed to move to the colon and provide the myenteric and Meissner's plexus to the colon does not happen. Okay, the migration of neural crest cells does not happen. As a result, the colon is devoid of your neural crest cells, and as a result, the colon cannot contract and propel food throughout. Okay, as a result, the food gets clogged up and there is no movement of food, and the intestines enlarge, and that's why it's also called as megacolon. Usually the tyrosine kinase RET gene is related to your Hirschsprung disease, and it's most commonly seen in your Down's patient. Okay, now I told this topic will be mostly about esophagus, but I'll be just covering the congenital and the acquired diseases of the GI tract in common before we jump into esophagus. Okay, atresia. The most common atresia is takes place in your tracheal bifurcation. Okay, atresia is an abnormal connection between two tubes inside a body, or two parts inside a body. So this is your trachea, and behind your trachea is your esophagus. There's an abnormal connection between both of them, and that's your atresia, and the most commonly is seen in your tracheal bifurcation. Okay, and there is also fistula. Fistula is a formation of a new root or a new canal or a new burrow. That's fistula. Okay, and the absence of organs is very rare in the GIT. Imperforate anus. What is imperforate anus? It is most commonly seen intestinal. Okay, imperforated anus from the colon and at the rectum. It's seen at the anus. It involves failure of cloacal diaphragm to involute. That's the pathophysiology behind it. So during the embryonal development, there is a cloacal diaphragm at your anus, and that involution is failed or absent. As a result, the anus doesn't open; it remains closed. That's your imperforate anus. Okay, and this imperforation is most commonly seen in your intestines. Okay, now about these fistulas, you need to remember these three types: esophageal, atresia, and tracheoesophageal fistula, A, B, C. A simple way to remember this is, if the fistula and the atresia contains a thin cord, that is type A. Okay, and if they both are combined, that's type C. Okay, and then other one is type B. Okay, so just remember A and C so that you can just go ahead and eliminate the option to choose B. Okay, so A is a thin cord, C is combined. Okay, yeah, those are the congenital and acquired diseases. Okay, now let's go to esophagus. Esophagus, you have nutcracker esophagus, diffuse esophageal spasm, and LES dysfunction. LES means lower esophageal sphincter. Nutcracker esophagus is when the lower esophageal sphincter spasms. Okay, the lower esophageal part spasms abnormally. Diffuse esophageal spasm is spasm across the esophagus in a diffuse pattern. LES dysfunction, we'll be talking more about it later. Now, let's say there is acid reflux or caustic injury due to some poisoning or radiation. These are all stress to your esophagus. To compensate for the stress, the cells in the esophagus can hypertrophy. Okay, and they can obstruct the esophagus, causing stenosis. Usually when this happens, this is called esophageal stenosis, and when this happens, usually the layer that thickens is your submucosal layer, and your muscularis layer atrophies. Okay, so layer that becomes hypertrophied is your submucosa, whereas your layer that becomes atrophied is your muscularis layer. Okay, another thing to know is esophageal webs and esophageal rings, the difference. Esophageal webs involves only your mucosa. So just remember it by W, just the opposite of W, the mirror image of W is an M. Okay, esophageal webs involve only the mucosa. Okay, and it's due to iron deficiency anemia or plummer vision syndrome. What about esophageal rings? It involves all the layers, and it's usually called Shadsky rings. Okay, this is the difference you should know. Now what about achalasia? Achalasia happens when there is a problem with your lower esophageal sphincter. When there is decreased relaxation of your lower esophageal sphincter, increased tone of your lower esophageal sphincter, or absence of peristalsis across your lower esophageal sphincter. As a result, what happens usually, esophageal related symptoms are your dysphagia, belching, pain during swallowing, all those things. Okay. There are primary and secondary achalasias. Primary is mainly due to this LES, but secondary is caused due to a protozoan called Trypanosoma cruzi, seen in Chagas disease. Okay, that's an example of your secondary achalasia. Okay. Now what about esophagitis? Esophagitis is the inflammation of the esophagus, as the word says. There's a type of laceration called Mallory-Weiss tear. Okay, this is due to alcohol-induced vomiting. Okay, retching, alcohol-induced vomiting leads to a laceration in the esophagus, and those lacerations are called Mallory-Weiss tear. What about cirrhosis? When there is liver cirrhosis, there is varices formed. Varices are nothing but your dilation of your veins, tortuous dilations of your veins. When there is cirrhosis, there is varices formed. What about chemicals that can cause esophagitis? Is your alkalate or acids, smoking, And what about infections? Herpes simplex virus or cytomegalovirus. Herpes simplex, to be specific, it causes deep ulcers and punched out ulcers, also known as punched out ulcers, and CMV causes shallow ulcers. Okay, and what about candidiasis? When there is candidiasis infection, there is grey white membrane formation along with your esophagitis in your esophagus. The most common esophagitis cause is your reflux disease, that is your GERD. Okay, GERD. This GERD can lead to Barrett's esophagus, about which we'll be looking in detail later. This is mainly due to transient LES relaxation. Okay, when there is transient temporary LES relaxation, that means the esophagus is allowing the stomach to put gas inside the esophagus here and there. As a result, the membrane there, the lining there becomes eroded, and that causes your GERD and in the future Barrett's esophagus. Okay, what's the pathophysiology? First you have eosinophils. First you have eosinophils coming to the site. After eosinophils, you have your neutrophils coming to the site. What are the symptoms? Heartburn. It's called heartburn. Classic symptom of GERD is called heartburn, and you have chest pain. Okay. Eosinophilic esophagitis is usually due to atopy. What is atopy? Atopy are conditions that exist from your childhood, like your allergic rhinitis, asthma, which really do not have a specific cause or is due to an allergy or something like that. Okay, atopy can cause eosinophilic esophagitis, where the esophagitis sample is dominated by your eosinophils. Okay, and in endoscopy, in case of eosinophilic esophagitis, you will see stacked circular rings, which is called Feline's esophagus or cat's tail esophagus. Okay, and this eosinophilic esophagitis is a decreased risk factor for Barrett's esophagus. So the chances of having Barrett's esophagus is more for GERD compared to eosinophilic esophagitis, decreased risk. Okay, now to explain how cirrhosis can cause varices in your esophagus, you should know the concept of portal hypertension. Okay, portal hypertension, that is due to cirrhosis, right-sided heart failure, alcoholic liver disease, or hepatic schistosomiasis, leads to portal hypertension. As a result, the veins become clogged with blood, and as a result, you have dilation of veins, tortuous course of veins. That results as your varices. Okay. Okay. Now, what about Barrett's esophagus? It is primarily due to metaplasia. Okay. This metaplasia can cause adenocarcinoma in the future. This adenocarcinoma is not only due to this metaplasia, it could be due to H. pylori, it could be due to chronic GERD, obesity, or tobacco consumption. So what exactly happens in metaplasia? Squamous cells become columnar cells. Stratified squamous lining will become columnar lining. You know, stratified squamous lining is more protective, columnar is more for absorptive, right? There is no absorption in the esophagus. You don't need esophagus to absorb anything. You need esophagus to be protected from the food that we consume, because that's the first place where the food goes through, right? So you need stratified squamous, but if that gets replaced by columnar, then that's going to be problematic. Instead of protecting, the esophagus is going to get damaged by the food that we consume. Okay, and this usually takes place in the lower 1/3 of your esophagus. Okay, in the lower gastroesophageal junction or your cardiac part of your stomach. Okay, and this can also cause dysplasia apart from metaplasia. The symptoms are dysphagia, hematemesis, and vomiting. Hematemesis, you know what is hematemesis? It's vomiting of blood. This can also spread to your nearby lymphatic vessels. Okay, a classic feature that is seen in Barrett's esophagus is a tongue of red velvety mucosa. Okay, and there are two types of Barrett's esophagus, less than 3 centimeters one and greater than 3 centimeter one. Less than 3 centimeter ones are the short segment one, greater than 3 centimeters one are the long segment one, and they have high risk factor for forming an adenocarcinoma. Okay, and this is most commonly seen in your lower 1/3, as I said, which is very important. Now, what about squamous cell carcinoma? Squamous cell carcinoma is due to alcohol, tobacco, achalasia, Plummer-Vicious syndrome, or genetic mutations in the SOX2 gene. This is usually seen in middle 1/3 of the esophagus. Okay, and this starts as a squamous dysplasia in situ. It doesn't escape the cell, it's inside the cell. Starts as a squamous dysplasia in situ, and then that goes and spreads out. So if it's in the upper 1/3 of the esophagus, it can spread to cervical lymph nodes. And most commonly it's in your middle 1/3, as I said, and it could spread to mediastinal and parasternal lymph nodes. If it's in the lower 1/3, it can spread to your gastric or celiac lymph nodes. Now that brings us to the end of your congenital and acquired diseases of the GI and the diseases of your esophagus. I hope you understood the concepts behind GERD and Barrett's esophagus and your achalasia and the congenital and your acquired disease. I hope this video really helped you. Thank you.